Welcome to Made One Peja. My name is Benjamin, and today I'm going to be talking about asthma. So, asthma is a chronic inflammatory disease of the airways characterized by a variable respiratory symptoms, that is, wheezing, coughing, chest tightness, and shortness of breath, and a variable expiratory airflow limitation. And throughout this video, I'm going to be explaining basically these concepts in the definition, because they are very key when it comes to pathophysiology and understanding how you're going to manage these patients. So, when you look at the pathophysiology, it's going to be mostly we're going to have a core triad of airway inflammation, and that is initiated by the T helper cells, the eosinophils, and the mast cells. They shall have airway hyperresponsiveness, which is an exaggerated reaction to a stimuli that would normally not cause a response that massive or that big in someone who does not have asthma. Then we have reversible obstruction, and that is by bronchospasms. It can be by edema or by mucus. So what happens in the early phase is that we have the IgE cross-linking on the mast cells. So what happens at first is that someone gets an allergen affecting them, and when that allergen gets into the body, it's picked up by the dendritic cells. The dendritic cells present it to the naive T4 cells, which go ahead and produce the antibodies, which deficient and lead to the production of antibodies, including the IgE. So the IgE is going to be produced, and it's going to be seated on the mast cells. So when the allergen comes back again, it is going to cause cross-linking of these IgE antibodies found on the mast cells. And when this happens, the mast cells are going to reduce histamine, leukotrienes, and prostaglandins. And these are all going to be very, very responsible for the symptoms that are seen in someone having asthma. For example, the histamine, the leukotrienes are going to cause the bronchospasms, and we can have mucus suppression, we can have airway edema, all occurring because of these mast cell products. Then we have the late phase, and this is going to occur about 3 to 4 hours afterwards, and they may last up to 12 hours. So what happens is that cytokines are going to be released, that is interleukin 4, 5, and 13, and these are going to recruit even more cells, the eosinophils, the neutrophils, and T helper cells. And they are going to also produce their products. The eosinophils are going to produce their products that will lead to epithelial damage, and this epithelial damage is going to also cause more sustained inflammation. And this leads to prolonged airway narrowing and hyperresponsiveness. So when you look at this, what we are having is an exaggerated inflammation coming in the late hours after in the early phase, which is basically short-lived. So what's going to happen if we have this coming up over and over again? We have this sustained inflammation, is that we shall have the chronic remodeling. And the chronic remodeling is going to lead to the structural changes like goblet cell hyperplasia, which is going to cause formation of mucus plugs. They're going to have basement membrane thickening, fibrosis, and then we have smooth muscle hypertrophy and hyperplasia. The neovascularization is going to take place to sustain this, of course, smooth muscle hypertrophy. And when this occurs, we're going to have a fixed component of obstruction, which is less reversible. So we don't want our patients to experience very many attacks, because over the years they will undergo this remodeling changes, and then they'll end up having a fixed obstruction that is actually less reversible. So there's something that is important to know, which is the T2 and the non-T2 asthma, or the type 2 asthma. And this one is driven by type 2 inflammation, that is by the interleukin 4 and interleukin 5. So when we have the T2 asthma or the type 2 inflammation, it is usually as allergic or eosinophilic. And when you check the blood for markers, you're going to see markers of eosinophilia. For example, when you check the blood, you have a high blood eosinophils, you have high sputum eosinophils, you're going to have a high fraction excretion of nitric oxide, which nitric oxide is a byproduct or is given off from the eosinophils. And then we have elevated IgE, and this one normally comes in childhood. And why it's important to know about this is because it has a good response to inhaled corticosteroids most of the time. So when we have severe cases of this, sometimes we may need the biologics like omalizumab, which is an anti-IgE, because you are seeing that this is an IgE-driven inflammatory response. So most common triggers are going to be the allergens or viral reactions. Then we look at the 9 type 2 or the non-T2 asthma, and this one is driven by is not driven by type 2 inflammation, and it's mostly going to be neutrophilic or have even very low inflammatory markers, and some textbooks call it the granulocytic type of asthma. So when you check the markers, you're going to find that there is normal or low eosinophils, and even the fraction excision of nitric oxide is going to be low, and this one commonly occurs in adults. And the response to inhaled corticosteroids most of the time is poor, and triggers can be obesity, smoking, infections, and pollutants. So in the future, we're going to look at the different phenotypes of asthma as recognized by the GINA, the Global Initiative on Asthma. So we have the clinical features of asthma, and most of the symptoms is that we're going to have a wheeze, that is an expiratory wheeze. We're going to have a cough, which is often nocturnal. We're going to have chest tightness and dyspnea. And some of the times you find people with asthma only presenting with a cough, which is called the cough-specific asthma. So these people are having a prolonged cough for a long period of time, and this could actually delay their diagnosis. Then another important thing is that we'll have to look at the pattern. Asthma is episodic, and often we have variable intensity, and it is most you're going to be harming or happening. We're going to have attacks after an allergen has triggered it. So it is triggered by allergens, but things like exercise can come in, things like cold air, things like infection and smoking, as well as aspirin. Because, infections are one of the things that cause the bronchoconstriction. So what happens when you give someone aspirin and you block the cyclooxygenase pathway? So we have two pathways of metabolism of arachidonic acid. That is the cyclooxygenase pathway and the lipoxygenase pathway. So if you block the cyclooxygenase pathway with NSAIDs, the lipoxygenase pathway is going to dominate, and the lipoxygenase pathway is the one that leads to production of leukotrienes. So if we have leukotrienes coming in, they're going to cause bronchoconstriction. So some people actually aspirin can be a trigger in that way. Then we have on physical exams, most of the time, if a patient is not having an attack, they may be normal. But during an attack, we may see a wheeze. They may have tachypnea, tachycardia, prolonged expiration, hyperinflation, and many other things. And when we see things like severe dyspnea, inability to speak full sentences, cyanosis, or a silent chest, those are very, very strong red flags, and they're telling you that this is a very, very severe asthma attack. Then we have the diagnostic criteria. So to make a diagnostic criteria according to the Global Initiative on Asthma, the GINA, you're going to require two components, and that is a history of variable respiratory symptoms, which means they are on and off. The respiratory symptoms are on and off, they're episodic, or they have different intensity. They are varying over time. And then you need to have evidence of variable airflow limitation. Once you have these two, you can make a diagnosis of asthma. So when you go to the history of variable respiratory symptoms, like wheeze, shortness of breath, chest tightness, and cough, you're going to need features that support asthma, and these are going to be symptoms worsening at night or on waking. So most of the time, the symptoms are going to be worse at night or when the patient is waking. We're going to have a trigger. Most triggers are exercise, allergens, cold air, or even laughter. And then symptoms that improve with treatment. And this is very important because when you go to the pediatric population where you may not be able to objectively assess their expiratory airflow, you may give them a trial of corticosteroids and see if they improve, and this will give you a clue to the diagnosis. So when we get to the evidence of variable airflow limitation, what you're going to do is basically do the spirometry, and this is the gold standard test, where we see an increase in the first expiratory volume in 1 second. So during first expiration, the first second, we want to see how much the patient is able to push out, or we can do the first vital capacity after the bronchodilator. And if we give a bronchodilator after and we measure the first vital capacity, we're going to see an increase of greater than 12% or greater than 200 mils in adults, and children is going to be more than 12% of the predicted. So the predicted is normally the normal. It's like there is a chart which has the normal values that are expected of children within that age, that range, that height, that weight. So when we get 12% or increase of the predicted, then we can say And this is asthma. Then spirometry is not a very common or widely used test, but we can have the peak expiratory flow mostly in resource limited settings. And what is going to happen is that you're going to take at least 3 readings in the morning and 3 readings in the evening. Then you record the highest recording. So you're going to do this over 2 weeks. The highest recording each day over 2 weeks, and you get the average. And that will give you the peak expiratory rate. So if the average difference between the peak expiratory flow rates between morning and evening is greater than 20%, then you can say that we have a diagnosis of asthma. Then if we have improvement in lung function after a course of anti-inflammatory treatment, that is inhaled corticosteroids, we can still say then we have the positive bronchoconstriction test where we give methacholine or evidence of hyperresponsiveness when other tests are inconclusive. So when you give methacholine, we are going to kind of induce that bronchospasms, and that is going to give us a clue whether the patient has airway hyperresponsiveness, which is a very, very strong feature suggestive of asthma. Then we have variation in lung function measured across visits. So someone comes in today, you measure the lung functions, come in another day, you measure the lung functions, and you look at the variability. Are they different? Are they changing over time? So there are some investigations we can do, and these investigations, we have the routine or the core ones, then we have the optional, the biomarkers. Other ones you may do if you see that things are not really improving, then we have the specialized, which you can do or you refer for them. So routinely what we can do is the spirometry, we can do the peak expiratory flow monitoring. Then we can give a trial of inhaled corticosteroids plus or minus a SABA to see if there is improvement. And we can do a chest X-ray basically to rule out most of the other diseases, because when someone is not having an attack, sometimes they may just have a normal chest X-ray. Then we have the biomarkers, and these are very important sometimes in determining a course of action. For example, we have the fractional excretion of nitric oxide. So imagine someone in a pediatric population who may not be very compliant to peak expiratory flow tests or spirometry. This would be a good test. If we can check for eosinophils in blood. This could be very, very strongly suggestive of asthma, because we saw it is an IgE driven or eosinophil driven inflammation. Then we can do IgE, then we can do sputum eosinophils. We can even test for allergies if possible. Then we have the specialized or the referral. We can do the bronchial challenge test like the methacholine, or we can do the exercise. We can have the sinus CT, we can do cardiac evaluation, we can do sleep studies, we can do GAD assessment to see if because remember, cough is one symptom that is shared both in GAD and asthma. So we have the GINA recognized asthma phenotypes, and these are, we have the allergic or the atopic asthma, and this one is a common one starting in childhood. We have the non-allergic asthma, we have the late onset asthma, we have asthma with persistent airflow limitation, and this occurs after years of airway remodeling. And then we have asthma with obesity that actually improves with weight management, but may not actually have a good outcome with inhaled corticosteroids. So when we go to the management, basically I'm going to just give you a small outlook of the management. Referring to your guidelines for your country would be actually more important when it comes to understanding the management, but the baseline is almost the same. So what happens is that inhaled corticosteroids are the basis or the foundation of management of asthma. So we are going to have different steps in management from step 1 to step 5. Step 5 being the highest step with the most severity and the most drugs, and step 1 with the least. So what's going to happen is that most of the times when you have someone who is having symptoms that are very mild, that is intermittent to mild symptoms which are less than twice a month, there's no night working, they have normal activity and they have normal lung functioning, but sometimes they get an attack once or twice in a month, we are going to consider giving them just a low dose inhaled corticosteroids and formoterol, or you can give them a low dose inhaled corticosteroid and the SABA reliever. So they're going to use this most of the time when they really need to, when they get the attack. So that is going to be the step 1. Then when we go to step 2, and this is where the patient actually has a bit of more symptoms on most on a little bit more of the symptoms, we can decide to give them a reliever on a daily basis, a preventer on a daily basis. So you give them an inhaled corticosteroid with formoterol, and that is also preferred mostly. And they're going to be using this for a few days, and most of the days as a reliever. Then other people sometimes they give a short-acting beta agonist for the patient to use when they get the symptoms, as well as low dose inhaled corticosteroids separately. And this one is also okay, but the inhaled corticosteroid with formoterol has been found to prevent more attacks and have better outcomes most of the time. Then we go to mild to moderate symptoms, and this one is having someone having more than 2 symptoms per week, with night waking, and greater than one time a month, and they have some activity limitation. So what we're going to do, we're going to go to step 3. We're going to give them a low dose inhaled corticosteroid formoterol as a maintenance, which means they're going to be using it almost every time, and then make sure they also have a reliever, which can be still the inhaled steroid and formoterol, or it can be a short-acting beta agonist like salbutamol inhaler. Then we have the step 4 where someone has daily symptoms, they have night waking. Of course, now you can see where we're going. These patients, you are going to need to give them, you're going to increase the dose of the inhaled corticosteroid, and you're going to give them a formoterol. Then sometimes, plus you have to make sure that they have a short-acting beta agonist reliever, that is salbutamol. Then when we have severe asthma, we are going to have someone with symptoms most of the day, frequent night waking, extreme limitations, and these ones are the highest level, and you're going to consider giving the highest dose of inhaled corticosteroids. You're going to give the long-acting beta agonist, and you're going to consider some add-on therapy. For example, the long-acting muscarinic antagonists, the biologics like anti-IgE, anti-interleukin-5, anti-IL, anti-IL-4R. Then we have the oral steroids, which always come in as a last resort because we don't want the systemic steroids because of their severe side effects. So we can have an exacerbation or severe attack, and really I'm not going to do it justice talking about it, an exacerbation here in a short time, but I'll make a video about it in the future, explaining the different ways how we approach someone with a severe exacerbation. But the principles are, we want to give oxygen, we want to give a repeated nebulization, or we can try using the inhaler to provide a SABA. We want to give systemic corticosteroids, and you want to monitor them very closely. And sometimes when we go to life-threatening situations, drugs like magnesium sulfate can be used, drugs like aminophidine. We can even end up using ketamine and intubating these patients. So while we are managing these patients, we are going to look at asthma control. We are going to see, are we controlling the asthma or are we failing to control? So whenever we fail to control, that's when we shall move a step further up. And when we attain control for about 3 months, we can reassess and consider stepping down the treatment. So I will reduce on the burden on the patient, as well as reduce on the side effects of the drugs. So we want to see, in the last 4 weeks, have we had daytime symptoms greater than 2 per week? Have we had any nighttime awakenings? Have we had to use the reliever more than 2 weeks in a week? Or are we having any activity limitation? So if we are well controlled, if we have controlled the asthma well, we don't have any of those symptoms. If it is partly controlled, we can have only 1 or 2 of the 4 symptoms. And in uncontrolled asthma, if you have 3 or 4 of those symptoms up, then we can say that asthma is not controlled. And the next step would be, you want to assess the risk factors. You want to know, is my patient stopping to smoke? Have they removed the allergen in their environment, or they still living with that dog that is giving them the reaction? So if you remove those risk factors, you can still reassess. Oh, you want to see, is my patient using their inhaler well? Are they adhering well to the drugs or the plan that we have? This is going to be very important, because before you increase the dosage, if a patient is not actually following up well with how they're supposed to use the drugs, it's going to be a very big problem. So the bottom line is that when we are doing the assessment of asthma control, we want to say, are we controlling the frequency of the symptoms as well as the risk factors? Because that is what will give us the good control of asthma. So at the end, at the end of this day, I'd like to talk about inhaler technique. And this is what you're basically going to do is that you're going to remove the cap that covers the mouth piece of the inhaler and check the inhaler. And you're going to breathe out gently and press the mouthpiece on the mouth. You're going to incline the head backwards to minimize oropharyngeal deposition of the drug. And then simultaneously, you will begin to inspire in deeply and slowly as you deep press the canister, and then you'll continue inhaling. And then you hold your breath for about 10 seconds and then breathe out and wait a few minutes and then repeat as required. So we have come to the end of this video, and I've been talking about asthma, and this is a very complex topic with very many important things to cover, and it's also very important on the exams. So if you have learned something, or if it's something that you have not understood well, I would be glad to answer it in the comment section. My name is Benjamin. This is Mid One Pager, and have a nice day.